Hello, this is Chris Ferrigno. In this video series, we will discuss the areas below the knee. In other words, all three compartments of the leg, as well as the foot. This series will be broken up into two parts. In this first of two parts, we will discuss the anterior and the lateral compartments of the leg, as well as the dorsum of the foot. In the second part, we will discuss the posterior leg and the plantar surface of the foot. We generally characterize ankle movements in two planes, the sagittal plane and the frontal plane. In the sagittal plane, the ankle can dorsiflex, or where you pull the dorsum of the foot up towards the shin bone, or plantar flex, where you put the plantar surface of the foot down towards the floor. Here in this picture, this is a picture of my 13-year-old daughter in Venice. This is St. Mark's Square. And she's plantar flexing here on her right limb and plantar flexing on the left. So she's doing a little on point in the middle of Venice, which I thought was pretty cool. In the frontal plane, one can either evert or invert. Here's a neutral foot. Everting is when the sole of the foot is turned outward. Inverting is when the sole of the foot is turned inward. In this image, this individual is inverting on both the left and the right foot. The leg osteology is rather straightforward, a warm-up of sorts for the foot. To review, the tibia has a medial and a lateral condyle. The top of those make up the tibial plateau. On the medial side, there's an attachment for the three tendons that make up the pes and serinus. On the lateral side, there's an attachment for the iliotibial band in this region. That area is called Gerdy's tubercle. The head of the fibula is where the biceps femoris attaches, as well as the lateral collateral ligament. And this is a key landmark for where the common fibular nerve courses. The head of the fibula tapers down into the shaft of the fibula. This taper region right here is called the neck. Anytime you have a head labeled on a bone, the tapered area is called the neck. The tibial tuberosity is the site of attachment for the patellar ligament, which is attached to the patella, which increases the mechanical advantage of the pull of the quadriceps muscle. As the tibia and fibula descend down, they're connected via a very robust interosseous membrane. The tibia has what's called the tibial crest. You can palpate this on the front of your shin bone. It's a very sharp ridge on the tibia. Thus, the anterior compartment will be lateral to that tibial crest. The distal tibia flares out three-dimensionally and medially sends off its medial malleolus. This is very palpable in the medial aspect of the ankle. Similarly, the fibula descends and flares out laterally as a bony projection called the lateral malleolus. These malleoli serve several functions. One, they give a robust attachment point for several ligaments. The malleoli also serve as functional pulleys for muscles and other structures that descend from the leg into the foot. In the case of the medial malleolus, structures that pass through the tarsal tunnel, which is posterior to this medial malleolus in this region, will course around the medial malleolus. And on the lateral side, the muscles in the lateral compartment will course posterior to that lateral malleolus. This slide is also a review from the joints of the ankle. However, I'll touch on just a few key structures. Again, we'll see the tarsal tunnel up in this region, posterior to where the medial malleolus would reside, just medial to the talus bone to which it articulates. We also see a couple other bony landmarks which the extrinsic muscles of the foot will attach to. In the anterior compartment, we'll see muscles attaching to the medial cuneiform and the base of the first metatarsal. In the lateral compartment, we'll see muscles attached to the tuberosity, this jutting of bone here off the base of the fifth metatarsal. We'll also see a muscle that descends down through this groove formed by the cuboid and this tuberosity. There are three compartments of the leg, and each are innervated by a single nerve. Here's a cross-section of the leg, roughly at the mid portion of the leg. Here in the yellow dotted region is the anterior compartment, and here we can see a summary of that anterior compartment. Here we see the lateral compartment, and here's a summary of the lateral compartment. And then you can see how large and vast the posterior compartment is in comparison to this anterior and lateral compartment. Again, today we'll be talking about the anterior and lateral compartments, and in the next video, as part of the series on the leg proper, we'll look at the posterior compartment. So again, here we see the anterior compartment just lateral to the tibial crest, which is this ridge of bone here that we can palpate anteriorly on our shin. We can see three muscles. You can see a tibialis anterior muscle, a extensor digitorum muscle, and a deep extensor hallucis longus muscle. Deep to these three muscles is the neurovascular bundle, the deep fibular nerve, and the anterior tibial artery and vein. Laterally, we can see the two muscles in the lateral compartment, but note that there is a fibula here, but there is no artery existing in this compartment. So we'll see that the artery actually descends in the posterior compartment, but like the posterior thigh, where there were perforating branches, we'll see perforating branches from a fibular artery that goes into this lateral compartment. We saw a robust layer of deep fascia in the thigh called the fascia lata. Similarly, in the leg, we see a deep layer of fascia called the crural fascia. Crural, or crura, meaning leg. Surrounding the leg is this crural fascia, and of course it has these indwellings of intermuscular septa that help to divide each of the three compartments, along with the bones. Once again, there are three main muscles in the anterior compartment, with a fourth being variably present. The tendons of these muscles cross the talocrural joint and are held in place by the extensor retinaculum that circumferentially wraps the ankle, thus preventing bowstringing of these tendons. If you palpate the anterior crest of the tibia, the tibialis anterior is that bulk just lateral. These muscles are extrinsic muscles of the foot. This means that they originate outside the foot, in this case in the leg, but insert onto the foot bones and therefore control the foot. We'll see a few of the intrinsic foot muscles in the second video of the leg. This slide discusses the specifics of each of these muscles in the anterior compartment and mostly reiterates the text in your notes. The most prominent muscle of the anterior compartment is the tibialis anterior, which attaches from the lateral proximal tibia and interosseous membrane and descends down to attach onto the medial cuneiform and the base of the first metatarsal. In addition to dorsiflexing the ankle, because it crosses the ankle over here on the medial side, it can assist with inverting the foot, or foot inversion. The next muscle we encounter from superficial to deep is the extensor digitorum longus. It originates from the proximal lateral tibia, interosseous membrane, as well as the fibula, and descends down to attach onto the distal phalanxes, the dorsum of those distal phalanxes. Therefore, it crosses the ankle joint, crosses the metatarsal phalangeal joints. It can dorsiflex here at the ankle, or at least assist the tibialis anterior with that, as well as dorsiflex or extend the MTP joints, or the metatarsal phalangeal joints, numbers 2 through 5. Under the partial cover of extensor digitorum longus as well as tibialis anterior, we can find the extensor hallucis longus. It's going to originate from the fibula, descend down, cross the ankle joint, cross the first MTP joint, and insert onto the distal phalanx of the great toe. Therefore, it also can assist with dorsiflexion of the ankle, but primarily its role is to dorsiflex or extend the first MTP. The last muscle we'll see in the anterior compartment is the variably present fibularis tertius, which arises from the fibula and inserts onto the dorsal surface of the base of the fifth metatarsal. Therefore, it can assist gently with dorsiflexion, but because it crosses and inserts onto the lateral foot, it can also assist with eversion, while the extensor hallucis longus and the tibialis anterior inserting on the medial side of the foot can assist with inversion. The fibularis tertius is present in about 90% of the population. The lateral compartment of the leg is very straightforward. There are two muscles, the fibularis brevis and longus, that both participate in eversion of the foot, or turning the sole of the foot out. They both attach to the fibula, as we can see in these two images, and their tendons course posterior to the lateral malleolus, which means that they both can contribute to plantar flexion of the ankle, in addition to eversion. Here we see two different fractures of the base of the fifth metatarsal. The picture on the left is an avulsion or dancer's fracture. As you can see here, it's an avulsion fracture, meaning that it's the tuberosity of the fifth metatarsal that gets avulsed off the remaining part of the base of that fifth metatarsal. This is often due to a very strong contraction of the fibularis brevis muscle. Recall that the fibularis brevis attaches here to the tuberosity of the fifth metatarsal. The typical mechanism is when a dancer lands in a plantar flex position and there's a strong contraction of the fibularis brevis to help stabilize the ankle during this plantar flex position. The radiograph on the right is of a Jones fracture. Here we can see a fracture where the base meets the shaft of the fifth metatarsal. The typical mechanism here is during a cutting event on the field or on a court, where the foot is plantar flex and there's forceful inversion, and the resulting impact fractures the connection between the base and the shaft of the fifth metatarsal. Now that we've seen the two compartments, let's talk about the innervation for these compartments. Recall that the common fibular nerve that we saw in the popliteal fossa courses around the fibular head. Right after it courses around the fibular head, it splits into the superficial fibular nerve and the deep fibular nerve. The superficial fibular nerve serves the lateral compartment, and the deep fibular nerve serves the anterior compartment. So again, how many muscles does the superficial fibular nerve serve? Just those two muscles in the lateral compartment, the fibularis longus and brevis. How many muscles does the deep fibular nerve serve? Well, there's three muscles plus the variably present fibularis tertius, so 3 plus perhaps 1. As we look over here to these two slides, we can see that the superficial fibular nerve has a very large cutaneous distribution. So it's along the lateral leg and almost the entire dorsum of the foot, with the exception of the area, the first dorsal web space, or the area between the first toe and the second toe. We call this the flip-flop area. So here you can see this yellow area served by the deep fibular nerve. How does the deep fibular nerve get there? Well, as it's coursing down the anterior leg in the anterior compartment, it ends up going pretty deep to the retinacula, and it stays deep. It's already served the 3 plus 1 muscles in the anterior compartment, and then it works its way back superficially to serve this area between the first and second digits. Once again, here we see the superficial fibular nerve, its innervated fibularis longus and brevis, and then it's split into several sub-branches to serve nearly the entire dorsum of the foot. A common orthopedic procedure is using a cast to set and properly heal a fracture, and it requires typically a 3-point cast mold. Leverage is important using this approach, and therefore bringing a cast as high up as possible is often desired, depending on the site and type of fracture. I've drawn in here the approximate location for the fibular head, and then the approximate location of the common fibular nerve before it branches into the deep fibular nerve serving the anterior compartment and the superficial fibular nerve serving the lateral compartment. If the course of the common fibular nerve is not taken into account when applying a short leg cast, the nerve can easily be lesioned. So question, what symptoms would you anticipate if a lesion to the common fibular nerve occurred? Well, we can now easily look downstream of the lesion, and we could figure out that if a lesion occurred here, both the deep and superficial fibular nerves would be affected. Therefore, the anterior compartment would be weak as well as the lateral compartment. This would result in a symptom called drop foot, where the person is unable to dorsiflex the foot when they are walking, and their foot would slap down against the ground. The patient would also have some sensory deficits here in the distribution of the deep fibular nerve, meaning in the flip-flop area between the first and second toes, as well as the distribution of the superficial fibular nerve, which would be the lateral leg and now the remaining dorsum of the foot. In these last two slides, I'll describe the arterial supply to all three leg compartments, including the posterior compartment. Once the popliteal artery enters the leg, it gives rise to an anterior and posterior tibial artery. We can see that better here. Here's the popliteal artery. Here we're now in the leg, and we can see an anterior tibial artery which shoots through a break in the interosseous membrane to go into the anterior compartment. And then we can see this posterior tibial artery. Off of this posterior tibial artery comes the fibular artery. Note that the posterior tibial artery and the fibular artery, jump over here, this posterior tibial and fibular both course through the posterior compartment of the leg. The posterior tibial artery is going to serve the posterior compartment of the leg before it then goes through this area called the tarsal tunnel, which we'll see more in the next video, to serve the foot. The fibular artery, while traveling down through the posterior compartment of the leg, is going to send off these branches into the lateral compartment, thus serving the lateral compartment. The anterior tibial artery, once it's passed through that gap in the interosseous membrane, it courses down underneath the cover of tibialis anterior, and it serves the anterior compartment. This vessel, after serving the anterior compartment, continues on in the foot. We can pick it up here on the right-hand side. Here is that anterior tibial artery. And then once it crosses the ankle joint, it turns into an artery called the dorsalis pedis artery, which is clinically very important because this is one of several arteries where we can find a pulse in the lower extremity. And when we're assessing circulation in the foot, we often turn to this dorsalis pedis artery to find a pulse to see how well circulation is getting diverted to the lower extremity. Let's go back to the picture on the left and we can make out this dorsalis pedis artery here in red. Note that it's just lateral to the extensor hallucis longus tendon. So one easy way to find dorsalis pedis, if you have a patient who's alert and can follow directions, is you have them pull up their big toe. When they pull up their big toe, the extensor hallucis longus tendon pops out, and you shift your fingers just lateral to that tendon up in this upper foot region to palpate the pulse. That concludes this discussion on the anterior and lateral compartments of the leg. Please be sure to check out the second of this two-part video series on the leg, which will cover the posterior compartment. As always, thank you for your attention, and please let me know if you have any questions or concerns.